I think we're going to go ahead and get started. I'm Michelle Niedens. I am the director of the Cognitive Care Network here at KU Alzheimer's Disease Research Center, and have been in practice for decades now, and paying special attention really to how do things work best for individuals going through this process. How do we see optimal care? How do we see the strongest chance for empowerment and families not getting lost somewhere in this process? And one of those areas that is very much important to me is this ability to work as a multidisciplinary team. And so we're going to talk some about that and get your thoughts and questions, etc. We don't need that one. So first of all, it is actually the direction. So healthcare has changed over time, and it is the direction we are headed, is that no one has all the answers, certainly not as it relates to dementia, that it takes a team. And we see that in this recognition of the relationship between healthcare and social determinants. We see that in the language in Medicare wellness checks. We see that in reimbursement models that have come out that address some of those pieces. We see that in these value-based elements in Medicaid and Medicare replacement plans. So the Medicaid replacement being PACE. We see that in the way medical education takes place. As we look at buildings that are not compartmentalized by discipline, but are shared, in classes that are attended by multiple disciplines. And we see that in an alignment with new partnerships. So collaboration in healthcare is not just, gosh, we all singularly weigh in together. It really is a joint process of problem solving. That some of the key pieces that you have as a MD are central to what I might do as a social worker, what somebody might do as a physical therapist, or the nursing staff. Some of those key elements that nursing has really goes into decision making of all those same kind of disciplines. So it's a collective process. It is not a siloed, everybody chipping in a piece. It is this collective shared movement towards decisions and care planning. When we think of multidisciplinary collaboration, there's a number of different models. Some are around co-located collaboration, meaning that disciplines are setting in the office. And we see that with the CPC Medicare models, where the supports are for behavioral health, for example, to be on scene, to be integrated in clinic services, or nutrition, dietary on scene. So co-located, that we're all in the same office and can step down the hall. Non-hierarchical collaboration, that we all come at it from a different perspective, and it is those perspectives joined together that produce the strongest outcomes. Collaboration through consultation is one of those multidisciplinary models. And I will say we've maybe seen more of that as virtual world became and telehealth advanced so profoundly in COVID aspects. And then simply what I would consider a more traditional collaboration, which is just referral and counter referral. What do we think of in terms of disciplines? As we look at a multidisciplinary approach, we think of nursing, social work, OT, physical therapy, dietitian, pharmacists, care managers sometimes, or chronic care navigators, and then telehealth through behavioral health aspects, or sometimes behavioral health team members on site. I will say what I see and I'm out and about lots. I talk to lots of people and lots of practices. And what I see mostly are in some of these models are nursing, social work, and pharmacist at play. But again, all of these disciplines are important and have something to offer. There's also some data on outcomes. We know that multidisciplinary approach works better when it's face-to-face. So sharing records, for example, might be the weakest way to collaborate. That is the most common, but the weakest, that it really matters when we're able to see one another and talk to one another, and when we're doing so in shared space. So when specialists come to provider practices and see patients, or if there's rural hospitals when specialists actually are on scene. So when data is accumulated together, that when there's some of the challenge with multidisciplinary teams is that we don't have shared EMR some of the time, or figuring out that mechanism to communicate. So data has to be accumulated. I mean, again, strongest outcomes are going to be with these elements in place. But what I will say is it can be constructed in a number of ways. What isn't realistic is for every practice in the world out there to hire every discipline that might be conceivably needed, that might have something to say, is something important to weigh in on the case. Not feasible. And so we've got to be more creative, and there's lots of ways to do that in terms of how do we access. I'm not going to belabor the challenges of dealing with dementia in primary care, other than to say you know them, you feel them, you live them, and that we're aware. And I am a realist. Whatever services that we want to advance, a model in which the ideal dementia service model is advanced, which is this multidisciplinary approach, we've got to figure it out together in the most realistic way so that it works for all team members and that we maximize those patient outcomes. What do we see? So when we think about how do we construct multidisciplinary teams, what team members are actually needed or that we can most benefit from, these are dementia-specific needs that are almost uniform, that are virtually uniform, that are dealt with every day in clinic settings. One, of course, is escalating losses. And that includes driving at some point, changes to life patterns, people that have gone through retirement or selling their farm, or having to give finances to their children. All of those things provoke some potential bumps in the road, certainly can contribute to depression, etc. The increased risk of depression, of course, is profound, and you've heard that in other pocket talks. We won't belabor that other than to say, if you're dealing with this population, you have to be expert in depression. And the way depression looks in dementia is a bit different. We see late onset alcohol abuse, certainly not with everyone, but it's not uncommon. Part of the time that's dealing with depression and losses, part of the time is they don't remember that they've had their 2 drinks for the day and keep drinking. So we see alcohol issues emerge that really were not an issue in earlier years. Relationship changes, every day I'm talking with folks where the relationship dynamic has been turned up on its ear. And sometimes that's because one person in the relationship had more control, assumed more control, needed more control. Sometimes we see the person that now is assuming the role of caregiver has been a historically passive individual and now having to take a more assertive role, which is difficult and sometimes impossible, and sometimes gets translated as non-compliant when actually it's trying to navigate these relationship changes. Loss of access to historical coping strategies, that if somebody coped by working or walking or, I had a long conversation the other day with a person who really their coping strategy was to be affirmed all the time. They were in a position where they got many, many accolades on a daily basis, and that really fed their soul. I mean, that was their identity. And absent of those accolades, we see irritability and decompensations. Really understanding those coping strategies. Our artificial or incomplete disclosure of concerns. People are hesitant oftentimes to talk about cognitive changes. They're hesitant to talk with their providers. I know a number of folks who have cognitive changes who study the screening tools, the MMSE or whatever, before they go in. They remember the questions and they study them before they walk in the door so they can perform better than they would normally. When it relates to onset of depression or onset of behavioral challenges, especially in terms of intimacy changes and those kind of things, are going to be more hesitant to bring it up so they don't share. Challenges in early detection, where we might even see normal MRIs, but we still have problems on board and need to take seriously. Extensive assessment set, that there is no symptom that guides us. It's all the triggers of the symptoms that guide us, and that takes some time. And then, of course, we have limited weapons in our medical treatment profile. So when I talk about the validity and the strength of multidisciplinary approaches and models, that is not born from one research article or several research studies. It is many, many research studies. And you see some of the major ones there, as we think some years ago about the Cleveland Managed Care Project, which began in these Medicare replacement plans and really looked at, when we place dementia specialized care managers, can we increase outcomes, including the reduction of healthcare costs? And it proved to be the case, and was replicated in California for many years. The PREVENT study went a bit farther. So most of these studies, however, we're going to talk about that, really focused on more behavioral or middle stage interventions, and we certainly want that dial to be moved up into early recognition. But the PREVENT study focused on those patients that were having those behavioral mood issues. And when they added dementia specialized care and support services, they saw a marked decrease in MPI scores. So they measured pre and post with the neuropsych inventory questionnaire, and it resulted in healthcare cost savings of $1,750 to $1,800 per participant. We replicated some features of the PREVENT study in Kansas in the late 2000s, 07 to 11-ish, and the implications were essentially the same. The PREVENT study reached a 7% decrease in MPI point scores, and the Bridge project reached an 8-point improvement. So there again, we're seeing both just the behavioral severity and the distress goes down, and that absolutely results in this cost savings. sufficient enough that it was this particular project was taken seriously when Kansas adopted the privatization of the Medicaid system. The care ecosystem, one that we're replicating now in Kansas in partnership with OCCK of Salina, and along with partners in Garden City and Waukene and Republic counties, and really looking at when someone is diagnosed, adding those additional pieces. For us, it's from the cognitive care network standpoint, it's replicating some of those features. Again, we see in Indiana, the Healthy Aging Brain Center, and not only did those support services improve patient outcomes, it increased efficacy and efficiency in those clinics, saving healthcare dollars. So what exactly, when we're talking about outcomes, what do we see? We see improved physical, emotional, and mental well-being for people with dementia and their care partners. We see improved identification and diagnosis of dementia, improved anticipation of deterioration and care coordination at end of life, which is reducing those futile aspects where people are accidentally, I call it accidentally, really engaging in procedures and treatments that are counter to the person's philosophy or that hold little to no long-term benefit. Reducing and delayed transitions into residential and nursing care, and obviously that is huge in the Medicaid realm. If we can reduce or extend people's time in community by even a few months, that saves the state Medicaid coffers thousands and thousands of dollars. And then reduced inappropriate hospital admissions, both acute and mental health, all of which is about improved communication between services. So some of you may know about and are familiar with our model. So we have very much paid attention to all these models. So the Cognitive Care Network has been in place about 4 years now, and absolutely developed with the learnings and the teachings from those other models, really partnering with primary care, which is where, in our estimation, the power is, the magic is. Those are the folks with the long-term relationships and have that more holistic view of the person. And so really looking at improving assessment, diagnosis, and management through education, not only of provider in programs like the Dementia Update or Managing Dementia with Dr. Townley and Dr. Burns, but also with clinic staff and the collective team together. Everybody is truly important in this picture, and dementia care is only going to be improved when we're all on board. And then we position a dementia specialized social work navigator in those practices to work with people once diagnosed. We visit those practices monthly. We have about 94, I think now, providers in the Cognitive Care Network, really with that emphasis on early diagnosis and integration of the navigator at point of diagnosis instead of point of crisis. And that takes an entire shift in how we present support services to patients and families. And the best approach to some of that is some language about the multidisciplinary team. That in this practice, we really see it as from a multidisciplinary approach. And when someone's diagnosed, we automatically refer and connect with the other disciplines. This concept of shared resources, that we all have too limited resources. We are all running busy every single day. We all have more patients, and and families, then would be ideal. And the way to manage the best we can is to do so collectively. And then integration of research opportunities. That research part is, guess what? That's part of the team. That's part of the multidisciplinary approach, affording those opportunities and allowing people to make that decision for themselves, and then using Zoom rooms. And through the Care Ecosystem grant, we will have available Zoom rooms in about 6 places through central and western Kansas. We did a provider survey in 2021, just looking at the CCN partnership. And again, I don't want you to hear just it's about the Cognitive Care Network and when our navigators are on board. Some of you have dementia specialized navigators or have care managers that are expert in dementia. And these results would be absolutely transferable to those situations. It's just looking at that multidisciplinary approach. So 60% said earlier that they saw benefits in earlier diagnosis. That's just phenomenal. 100% indicated that it was helpful to have practice-based resource. We've got to be creative about these resources. 60% said better able to have conversations with patients, especially in early stage regarding their diagnosis and changes, area we all need to work on. 80% reported benefit by patients seen by the CCN Dementia Specialized Navigator, and 80% said reduced non-medical calls to the practice staff. So we're talking about efficiencies. We're not talking about added burden. We're talking about efficiencies. So in identifying trends and needs, we look at the trend through medical records. So sometimes how we identify needs is coming through with specific codes. That's one consideration. Really looking at the balance of general need versus specialized need. And by that, I mean, we don't have to identify a specialized need. We may approach it from a more generalized approach. Community partnerships is a consideration, shared education space, doing education events together, and then really facilitating tele-specialist visits. We found out in COVID that lots of folks did not have technology, did not prefer technology, even if they had access to it, really prefer having some sort of warm handoff. And we're testing that in these Zoom rooms in central Kansas and western Kansas. And we will see if there is a way to merge a warm handoff with telespecialist visits. Certainly, if you have questions and comments, this would be the time to throw them in. I'm looking at the chat. I don't see any questions here. If you're interested in learning more or having additional conversation about multidisciplinary team translation for your environment, please let me know. We do many things, and including education for care managers that currently exist in practices. So we go out to practices, but we also think educating on site for those that have that option is valuable. Questions, comments, especially from any of you who are working in a multidisciplinary approach, I would love it if you could jump in and share a little bit about your experience. And hearing none, we're going to jump off for today. Usually Michelle talks too much. So know that you have just experienced a rare phenomena in Michelle not only staying within the time frame, but doing so with a few minutes left. So thank you much for your time. Have a good weekend.
Thank you, Michelle.